think intraoperative radiation is critically important, particularly in Africa and sub-Saharan Africa. So the first role would be in patients who have luminal A small cancers and are required to travel distances, and access into radiation facilities is difficult. They would come to the unit, and when we do their surgery, the first thing we would do is, and we do it all at one stage, I'd start with the sentinel first. I use mag trace for that, and the pathologist confirms I trace in the sentinel, and that the sentinel is negative. It's the only time we analyze the sentinel directly in theatre. I'm very privileged that I have good pathology in theatre, and as soon as you know that's negative, then we'll take out the tumor and give a single dose of radiation in theatre. And obviously we'd use different size balls depending on the size of the tumor. So almost all our patients, about 99%, will get an immediate reconstructive procedure at the same time. So I'd be working hand in hand with an oncoplastic colleague, just speeds up the average time in theatres under an hour and a half for almost all our patients, with a hospital stay of under 36 hours. So this will all be done at one time. So that is the use of the target A data, and we use it for people who travel from a distance. And we see a large number of people preferentially choosing that here in South Africa. And that obviously we, as it's an accredited unit, will follow the guidelines, the ASTRA guidelines, in terms of single dose radiation in theatre. Where else do we use it? So with a single dose in people who are using target A criteria, we have a subset of patients who have prostheses in, and they're small breasted. Obviously with the prostheses now, they are slightly bigger breasted, and they actually like the look of the prostheses. So what we often do is, in those patients, we'll give the single dose radiation. If they need replacement of the prostheses, we will do the surgery, give the single dose IORT, obviously again on criteria of node negative and fitting criteria. And then what we will do is replace with new prostheses, and the woman walks away with a nice aesthetic look that suits her, new prostheses, as well as having the benefit of single dose radiation. What we've also found is that if you look at the next subset of patients, we often use IORT from a boost point of view, which obviously that's part of target B, and that trial data and a provider will be released hopefully later this year. That would be using IORT as a boost. We have other scenarios that we've utilized it and actually written it up from a case report point of view. And that's, for example, frail elderly people with pacemakers in. What we found that we can use a single dose, we can use IORT, and we can place the ball up to 2.5 centimeters away directly from the pacemaker with no problem at all to the patient. And those patients offer a subset of patients that are quite difficult as clinicians to treat. I think there's lots of further opportunities, particularly from decreasing distance and time with IORT. Maybe looking at, we're currently looking at the possibility of trials around single dose IORT and maybe short duration, single week radiation, looking at whether we should get to nodal or not, depending on the initial upfront. Like I said, many people in the unit, many patients will start with primary oncology treatment. So we utilize our triple negatives. We'll usually start with primary oncology, cytotoxics, and immune. And that's obviously as long as they don't fit into that small subset of salivary glands and adenocystic triple negatives. Our HER2 positives are what I call our classic subset, the ER/PR negative HER2 positives, the ER positive PR negatives. Our luminal B subsets also will start with primary oncology treatment, and depending on the funding, sometimes dual therapy. And in those patients, looking at post-surgery boost with IORT, we quite like doing that. Then obviously our HER2 positives that are TRP positives with low KIs, those patients would usually start with primary surgery. So how does our MDT? We have a very, very good digital IT aspect to the unit. and that actually publishes and presents throughout the world on how to set up digital MDT. So in fact, what we found in the unit is that when it came to COVID, we didn't have a stressor at all, and our MDMs are recorded. They are divided into subsets. So a subset of newly diagnosed patients to the unit, and with all doctors virtually on the meeting. We look at the radiology, we look at the pathology. If the pathology is coming from external sites, it is internally in-house reviewed, which is really standard for accredited units throughout the world. Obviously, that's recorded and saved in a safe domain, and decisions are then made. We have navigators, at least 4 navigators on the MDM during the MDM, where patients are discussed and decisions are made. So the clinical, the radiology, the pathology, and the decision-making process up front, with about 70 of the patients, like I said, starting with some form of primary oncology treatment. The next important aspect from an MDM is we have a subset of patients who treated elsewhere, started treatment, and those fit into newly diagnosed, already on treatment, and that's a subset of that. Then a small subset on the MDM, so the MDMs last from about 06:30 our time. It's about a 3-hour MDT. We have where we go over the oncotypes, just check, particularly in the younger patients, or the oncotypes that are sitting on that 25-26 border. And we're quite conservative in terms of how things work. So, for example, any patient who is starting with primary surgery with a very small tumor, and elderly patient who we may be able to avoid radiation, those patients will still have a discussion with the rad-onc in the unit, so that the I's are dotted and the T's are crossed. Another aspect of the MDM is all post-operative patients are presented by, usually from someone from the reconstructive or oncoplastic team, where they go over original core biopsy, discrepancies between the core and the final histo. What we do on every single patient is we repeat the ERPRs, HER2s, and the KIs. And every now and again, you find a tumor with tumor heterogeneity. So, for example, the core biopsy showed it to be a luminal B tumor, and the final histology shows about a 20% HER2 positivity. And that obviously is relevant. And as we move more into the area of treating HER2 lows, I think that's going to be more important. So big MDM, we do path reviews. We generally put together either an online presentation, an academic, and a case report once a month through the MDM. And we also have the prehab and the rehab team on board, as well as the survivorship team and the genetics team as well. And they access into the MDM data, where they will contact in with the patients to ensure that they have access to oncology dietetics, prehab and rehab, so how to improve management during oncology process, diet, weight loss, survivorship. In fact, we're coming up in the next 2 weeks. One of the oncologists is going to put together, looking at the new phase around the world of injectables in terms of weight loss from an insulin point of view. And what we are wanting to see is how we can combine that into ensuring helping particularly our luminal patients who are sitting with a slightly higher BMI, to get them into a program of dropping BMIs down, because as we well know, that improves outcomes, and particularly tolerability from an endocrine treatment point of view. Numerous ways, through navigators. Navigators sit in the MDM and they contact out. So post the MDM, I do a sign off with the navigators to make sure that everyone has minuted and recorded everything correctly. The patients are contacted in by the navigators. Patients are contacted in by myself. They're contacted in by the oncoplastic team or the oncology team. In fact, we put together a very interesting abstract presentation, which has actually just been published, on time to treatments. So in other words, from our diagnosis, setting up things such as MRI and discussions in MDTs is within 2 days. and feedback within 2 days. So we've set up a concept of 2, 4, 6, 8. So within 8 days on 2. And that is not to push patients, but that is to ensure that the unit is efficient. So I want to stress that when it comes to a person going through a cancer diagnosis, it's their body. They have a right to second opinions. They have a right to accessing information. They have a right to taking time about their decision-making process. But from a unit point of view, effective, efficient unit working is critical to ensure patients are held through a process right from the start of diagnosis, right to treatment and survivorship, which forms part of and sit on the MDM. So you can pick up straight away someone who's battling from a psychology point of view. We have a nice oncology psychology group in the unit where we will quickly contact in with that patient and say, how can we help, in what way, and also palliative care. So it's about whole patient care, and I think that is what we should be striving for in all our units today, which is why intraoperative radiation is a critical aspect of providing whole patient care. It's, for example, we have prior surgery as well in the unit, and that's played an interesting role in a small subset of ill patients during the SARS-CoV-2 pandemic, where they'd finished out on their chemo. We'd used slightly different chemo regimes, and we cried and froze the tumors to buy them time till they felt safe to access into the hospital environment. Advice I have is that I think as a community, we must work harder together to ensure it's part of the armamentarium that we offer to patients. There's not one size fits all when it comes to oncology and cancer and patient care. And whereas we see a trend of patients who may not require radiation today, there are patients who single dose IORT or IORT as part of is often very useful to someone from a distance, from a travel, and from a cancer outcome. What I'm going to put a little teaser out there is we're currently looking at spectacular research around the immune benefit of the low-dose IORT in theatre. So it's fascinating to see what's happening at a cell level. So from a community point of view, I think all of us in the breast health and breast cancer field need to collaborate. We need to understand that there are many different ways to treat people, and we must work together to ensure that we have different aspects of technology when it comes to treating our patients so that we can offer them best, safest care.